almost time to start.
It's 4 o'clock, so go ahead and start. I'm gonna mute myself.
Since everyone is remote anyway. So welcome to everyone to today's Endocrine Grand Rounds. As you know, because of severe tornado warning, we decided to do it entirely virtually. So everyone will be in a safe place, and if not, make sure that you are in a safe place. So today we have our own faculty, Malika Rawal, who will be giving us the talk. Dr. Rawal started her endocrine fellowship here in 2019 and graduated from our program in 2021. She joined faculty in August of 2021. She is originally from Pittsburgh, went to undergraduate school there, then did her medicine at St. George's, and came back to do residency in Pittsburgh. And she came to Louisville in 2019. Since then, she has been here. She's been very popular with our students and residents and our fellows. She has been very active in developing a clinical program with her special interest, particularly with transgender medicine. And today she'll be talking to us about a very interesting topic of hair there everywhere, look into the etiologies and management of endocrine-related hair loss. So Malika, all yours.
Thank you so much, Dr. Mokshikandam, and good afternoon, everyone. I'm so glad that we can all join virtually and get comfy because I have a lot of things to tell you guys. When I took on this topic, it was something that came up often in patient visits, and I wanted to see what I could find out to help them. And gosh, I realized hair is very complex. So my disclaimer is that I am not an expert in hair, but I hope to provide some evidence that I found so we can better serve our patients and help them return of hair loss. So as always, I have no conflicts of interest to disclose in relation to today's talk. And the framework of why I chose this discussion. So I've heard it said amongst other endocrinologists outside of our university that you're not really an endocrinologist until a patient has brought you a bag of hair out of frustration that they're just having so much hair loss. And, hyperbole aside, this is something that comes up often in patients, whether they already have pre-existing endocrine conditions like diabetes or thyroid disease or PCOS, or whether it's a new patient consult because of fatigue, hair loss, and constellation of symptoms, which could be related to endocrine etiologies. And so it's something that we should be aware of and know how to address. In addition, hair is important. Hair adds to our psychological well-being. It adds to our personality. And, there's some truth behind the phrase, having a bad hair day. It kind of sets everything off. And in some cultures and societies, hair health is also considered a sign of your overall health. So losing scalp hair could be pretty devastating to patients. In addition to that, there is a slew of information on the internet about hair loss, including a link between thyroid disease and hair loss, which brings up 31 million results on Google. The connection between hair loss and hormones, which pulls up almost 11 million results and pulls up a variety of hair supplements that you can purchase for close to $100 per bottle. And also, things like laser illumination caps, which might also help you with your hair growth, only for $700, not too bad, right? In addition, you look on posts on streams like Reddit, and there's tons of discussion posts about what is the correlation between hair health and thyroid disease, hair health and hormone disease. So this is something that I really wanted to learn more about, and I hope to share with you guys. So the objectives today are to review the basic anatomy of hair and its life cycle, to figure out how we classify or differentiate patterns of hair loss, and to highlight how the endocrine system is related to hair loss and hair growth as well. And finally, to talk about how we should counsel our patients and manage hair loss depending on the etiology. So getting into the hair anatomy and life cycle. So here we can see is the histological cartoon of the hair follicle and hair unit. And basically there are two parts we need to consider. The hair shaft itself, which is the part that emerges from the skin, and then the hair follicle, which is below the skin and embedded in skin. And so the follicle is really the living part, and this is the place where the blood supply goes to the dermal papilla at the base of the hair follicle, where the nerve supply is, where the stem cells that create new hairs are migrating to, and really is the active part. The hair shaft itself is fully keratinized, non-living part of the skin that is above the skin surface. And it is an association with musculature, which is innervated by autonomic nervous system and helps us with circulation, etc. But it is a non-living part. There are multiple different elements to the hair shaft and the hair follicle itself, which are kind of beyond today's topic. But as we go on and talk about the different patterns of hair loss, I might reference some of these parts, and I'll try to put them in context as well. So hair growth occurs in 4 stages, named here. They are the anagen phase, catagen phase, telogen phase, and exogen. The end of exogen starts a new anagen phase. And it's important to know that in humans, hair growth on the scalp is not synchronous, meaning we have hair follicles and hair shafts all over our scalp, which are in different stages of this hair growth cycle at all times. And so that kind of plays a role in the different pathologies that we're going to see. The anagen phase is named the growth phase, and this is the only phase in which there is actual growth of hair and elongation of the hair shaft. This phase lasts about 3 to 7 years, and in most cases up to 5 years on the scalp, and it accounts for about 85 to 90% of the hairs on our scalp at any one time in a healthy individual. And the anagen phase will vary depending on the location of the hair we're talking about. Obviously, our eyelashes and eyebrows have much shorter and regenerate in shorter periods. And the typical scalp hair growth is about 1 to 1.5 inches per month, and it is seasonally variable, which is something I did not know. So in warmer months, hair growth tends to be a little bit faster. The next phase is called the catagen phase, and this is a phase of transition. This phase is very brief. It's about 1.5 to 3 weeks long, and it accounts for a very small percentage of hairs on our scalp, about 1 to 3%. During this phase, the hair follicles shrink and their growth will slow, but they haven't actually separated from the follicle completely. They start to separate, but they're not quite dead, they're not quite shedding, they're just kind of waiting for the next. Next comes telogen, and this is the resting phase. It lasts about 3 months, and it's about 10 to 15% of all scalp hairs. During this phase, again, the hair shaft is quiescent, it's neither growing nor shedding, but it becomes an adult final hair, which we call club hair. Underneath the base of that club hair, in the dermal papilla of the follicle, a new hair shaft is going to start to grow and begin its anagen phase down below the club hair. The telogen phase is one of the main targets of the hair cycle by modulatory hormones such as androgens, prolactin, ACTH, thyroid hormone, and so really a lot of the endocrine conditions affect this phase in particular. Finally, we reach the exogen phase, which is shedding of the hair, and this lasts up to 2 to 5 months. So on a normal person, shedding 50 to 100 hairs per day is actually considered normal during the exogen. And in this time period, there are new hairs growing down below that will eventually emerge from the skin as well and develop their hair shaft. So how do we actually classify hair loss or alopecia? This is a very broad field of study and field of medicine. So I'm going to try to provide some basic overview. But the first thing to classify alopecia is to look at the scalp and consider if it is normal or abnormal appearing. An abnormal looking scalp with scarring indicates scarring or cicatricial alopecia. And examples of conditions which cause this include traction alopecia, which is caused by tight hairstyles, psoriasis, lupus, dermatophyte infections, and seborrheic dermatitis, where the actual skin itself is affected rather than just the hair follicle and the hair shaft. In non-scarring alopecia, we further classify by whether the hair loss is diffuse or localized. Diffuse hair loss can be classified into two main etiologies, either anagen effluvium, which is loss of those anagen growing hairs, or telogen effluvium, which is loss of those resting hairs that have yet to be shed but are not growing any longer. Localized alopecia, we see conditions such as alopecia areata, trichotillomania, where patients actually pull their own hair out, effects of secondary syphilis, pattern hair loss, such as in androgenetic alopecia. So we're going to touch on these in a little bit more detail. First, I wanted to talk more about alopecia areata. And so this is an example of a localized, non-scarring alopecia, and it is autoimmune and inflammatory in nature. And so it leads to patchy hair loss as seen in this picture here. During this condition, what we can see is increased number of hairs in the catagen and telogen phases, meaning they're no longer elongating and they're just resting and waiting to be shed. Also, if you were to do a scalp biopsy, you would see lymphocytic infiltrate in the peribulbar region of the hair follicle. And this is classic for this condition. Anagen effluvium is one of the diffuse non-scarring hair loss patterns, and it's usually caused because of a sudden profound disturbance to the matrix of the hair follicles and the supporting structure. Most commonly, we see this in use of radiation therapy or chemotherapy for cancer. Telogen effluvium is something that is very common and has a variety of causes. In this condition, the anagen phase or the growing phase is prematurely terminated due to an acute trigger with the potential to become chronic depending on the offending agent or offending cause. In this condition, because anagen is arrested, we see a greater proportion of scalp hairs actually in the telogen phase. So it's not that they get converted to that phase, but just the ones that are supposed to complete anagen no longer do. And so it seems as though there's an increased proportion or increased shedding of telogen hairs in relation to anagen hairs. And sometimes there could be shedding of up to 300 hairs per day during this condition. Some common causes include severe infection or fever, shock of any cause, endocrinopathies, which we'll discuss, chronic dermatitis, such as with chemical dermatitis from hair dyes or other such agents, a number of medications, stress in general, chronic inflammatory states like cirrhosis, chronic kidney disease, systemic amyloidosis. Iron deficiency is also associated with telogen effluvium, and particularly with ferritin levels less than 30 micrograms per liter. And then inadequate nutrition, so deficiencies of zinc and essential fatty acids to development telogen effluvium. So these are some of the medications, and I was kind of taken aback by this because these are common medications, a lot of them. So, isotretinoin for treatment of acne, common antihypertensive agents, diuretics, beta blockers, nonsteroidals, are tamoxifen and SERMs, anticonvulsants. So, and even oral contraceptive tablets have been associated with telogen effluvium, as well as stopping use of oral contraceptives. So there's a wide list, and so all of these might be contributing to this patient. So history taking is very important if we. So once we have a patient that's complaining of hair loss and wants to be evaluated for it, how do we evaluate it? So apart from just looking at the scalp and determining if it's scarring or not scarring, diffuse or localized, There are some specific tests which are recommended, some of which we can do ourselves, and some probably require a dermatologist's help. So the first is the pluck test, and this can actually even be done by patients. And so basically, what they recommend is that they pull out their hair at the root, and then they bring it to us, and we look at it under a microscope. If the hair looks like the hair shaft has the root attached and the sheath around, that's an anagen. That's the growing hair that was still generating. If the hair has its root attached but no sheath around it, there's no further growth, and that's a telogen hair. The normal proportion of anagen and telogen is about 12:1 or 14:1, and if that proportion is lower, meaning we see more telogen hairs, that might be a sign of telogen effluvia. Another test that can be done is the pull test, and this is really helpful in patients that are complaining of diffuse hair loss. This test is where basically you ask a patient to grab about 30-40 hairs and put gentle traction on them, just like they're combing their fingers through their hair, and to do that in 3 separate locations of the scalp. If they pull out more than 10 hairs, then that's considered a positive test and might indicate an underlying condition. A dermatologist can do a scalp biopsy, which can help to differentiate between scarring and non-scarring forms of alopecia. Also, there are daily hair counts, and so these are a little bit more tedious, and I think there are some patients that are going to be very willing to do it, but again, it's a labor-intensive test. And basically, this is a follow-up to the pull test. So if you do the pull test and more than 10 hairs come out, the next recommended thing is to do a daily count, where basically patients should collect their hair and count them after brushing or shampooing. If more than 100 hairs fall after brushing, or more than 250 hairs fall after shampooing, that might indicate that there is abnormal diffuse hair loss that should be investigated further. And again, those hairs can be investigated via microscopy to further determine if they're telogen hairs, anagen hairs, and what further investigations need to be undertaken. So specifically talking about some patterns of endocrine-related hair loss, we're going to start with androgenetic alopecia. And so this is hair loss that's related to excessive androgens and affects men and women both. Androgens do have a normal role in hair development, specifically during puberty and development of secondary sexual characteristics. So as we're born, most of the hairs on our body are these vellus hairs, which are thin, short, unpigmented hairs, not visible to the naked eye. And they stay that way up until puberty, when testosterone and its conversion to DHT causes these hairs to become terminal hairs, which are dark, coarse, thick, and visible. And in men, this happens in areas such as the axillae, the groin, face, and trunk, and in women in the axilla and groin. Also, androgens are noted during puberty to increase the size of the dermal papilla, so increase the blood supply and the stem cell supply and the matrix supply to a growing hair, more thick, more rapid hair growth. They increase pigmentation of hairs and also increase the duration of the hair cycle. So the anagen phase becomes longer and there's more hair growth before they become quiescent. But when this becomes abnormal, and specifically related to scalp hair, is when we start seeing androgenetic alopecia, which sometimes is abbreviated as AGA. So when this happens in men, we call it male pattern hair loss, or abbreviated MPHL. And so during this condition, testosterone and dihydrotestosterone activate intracellular androgen receptors in the dermal papilla cells. And the overall net effect of this is that there's increased keratinization and the anagen duration gets decreased. It gets cut short and telogen phase gets prolonged. And so what happens over time is there's progressive, what they call miniaturization and thinning of scalp hairs. Miniaturization because the anagen is shortened, so hairs can't grow as long, and thinning because more hairs appear to be telogen and they follow their destiny and end up going to exogen and getting shed. So overall, less new hair growth on the head. And so in male pattern hair loss, this is seen most commonly in the frontotemporal region and on the vertex of the head. And it does follow a polygenic inheritance. It said that it's inherited from our mothers, it's a mitochondrial inheritance, but it involves alteration of genes coding for androgen receptors and how they respond to stimuli. There is a classification pattern here called the Norwood to Hamilton classification, which goes from stages 1 to 7. And as you can see, as we progress from left to right, that there's increased loss of hair in the temples and along the vertex of the scalp, characteristic of this specific entity. On closer inspection of the scalp, what is notable is that there's a decreased density of hairs, but also if you look at each follicular unit, there should be 2 to 5 hairs coming from each follicular hair unit, but in some places we see only 1 or 2 hairs emerging, and that's evidence that there's decreased anagen and decreased growth of new hairs. One sign that they note on that is specific for male pattern hair loss and female pattern hair loss is what they call the peripilar sign, where there's a brown dot around the base of the hair shaft, and which signifies inflammation in that area. Also, we can see what's called the yellow dot sign, which is accumulation of sebum in the infundibulum of the hair follicles just prior to the hair shaft emerging from the skin, because there's no hair growing there. So the sebum is exiting, but there's no hair around for it to lubricate. In female pattern hair loss, we see similar things in that it also is polygenic in inheritance, and specifically they cite a shorter number of CAG repeats in the androgen receptor gene as an increased risk factor for developing this. Again, it's also related to increased action of testosterone and DHT on androgen receptors in hair follicles, and it's more common to occur between the 3rd and 5th decades of life and then increase as age continues. It seems to be less common in Asian women. In a study that was done in China, they saw that there was much lower incidence compared to that of European and African American women. So basically during this, again, there's increased conversion of the anagen hairs to telogen. So overall, there's thinning, there's less new hair growth, and early on in the course of this, they may actually have a positive pull test, which indicates diffuse hair loss, even though we know that this is a patterned hair loss and only affects certain areas. So in female pattern hair loss, unlike male pattern hair loss, the frontal hairline is typically preserved, and so we don't get that M shape in the front that we see with male pattern hair loss. And what we do see, though, is that there's loss of hair along the part, the central part, and slowly it extends towards the vertex of the head. When we look at the hair under microscope and do trichoscopy, we can see similar things as that which we saw in the male pattern hair loss, namely that there's a variation in hair shaft diameter, there's more follicular units that have only 1 or 2 hairs coming out, and then we see that peripilar and yellow dot sign as well, indicating that there is less new hair growth and there's inflammation around the hair follicle. And so similar to male pattern hair loss, there is a classification system which is called the Ludwig scale, which indicates different severity and is often used in studies to see if interventions are actually helpful in treating hair loss. So they ask patients and physicians to grade them on the Ludwig scale and then compare it after they've done it. So how do we treat pattern hair loss? In women, if there is hyperandrogenemia, the treatment is correction of that. So patients that have polycystic ovary syndrome, patients that are having prolactin excess, patients that have hypercortisolism, or any other reason for hyperandrogenemia, correction of the underlying cause may help to slow the progression and maybe even reverse some of this pattern hair loss if there is not scarring from the inflammation. One medical treatment is minoxidil, and that comes in different concentration solutions. From the studies that I read, it seems to have less side effect or irritation on the scalp if it's applied once daily, and they recommend actually using the 5% formulation to be more efficacious. You can also use other anti-androgen therapy, similar to the treatment for hirsutism in these hyperandrogenic women, So agents include things like cyproterone acetate, spironolactone, flutamide, and finasteride, or other 5-alpha reductase inhibitors. And honestly, overall, the efficacy of these is not great, but they are targets specific to the cause for this pattern of hair loss. Other treatments include hair transplantation, stem cell treatments, and then a temporizing measure, because as I mentioned earlier, this is a psychological thing sometimes and has to do with our emotional and psychological well-being. Some women choose to wear wigs or hair pieces to cover their areas of alopecia until they find a more long-term treatment. So as I said, most of these agents are not great. So particularly I looked at one study in which they took 12 women they took 48 women that had androgenetic alopecia or female pattern hair loss, and they treated them with either observation, finasteride, flutamide, or cyproterone acetate. And they asked them at the beginning to give themselves an alopecia score, and they averaged that with the investigator score. They all started at about a Ludwig scale 2.1 to 2.3, so moderate hair loss, and measured at baseline their total testosterone, free testosterone, and THEAS, just to make sure there was not a difference in androgen levels and how they responded to treatment or the severity of their disease. And they tried to randomize them as best as they could and put them in these groups. So what they noted at the end of this is that really only flutamide in the dark black bar showed any significant decrease in the patient's self-rated scores of hair loss and in the investigator Ludwig scale scores, with a 21% decrease in hair loss. But this comes with some risks. So flutamide has been associated with liver damage, and so it's not to be used without. So next is thyroid disease and hair loss, and this is a big topic. And surprisingly, I couldn't find too much information about the specifics, but thyroid disease has been long linked to hair loss, and a lot of patients come to me after being euthyroid, and they tell me that they're still losing hair and they don't know why. And a lot of times their hair fall, to them, is an indicator of their disease status, so they think that the weight gain they're having in their hair fall means they're untreated, or they attribute other symptoms to their thyroid disease because of their hair fall. So I wanted to look into the relationship, really. The question I had is, does thyroid disease cause hair loss regardless of whether they're treated? So if they're euthyroid, will they still have some hair loss for some reason? And then what connection does thyroid autoimmunity play with hair loss? Does it have any causation to hair loss? So in general, what we know is that there are thyroid hormone receptors on hair follicles, and they act in concert with the outer root sheath cells, which are part of the hair follicle. And these outer root sheath cells actually undergo keratinization, and they form something called the bulge region in the infundibulum of the hair follicle. And basically, this all kind of initiates and helps to promote growth of the hair itself and the hair shaft, and proper nutrition of the hair shaft, and kind of promotes the anagen growth phase. And so thyroid hormone definitely has an important role in hair health. Now, patients that are hypothyroid, they have reduced mobility of those stem cells, which are the precursors and generate new hairs and help us to have more hairs and anagen. And so if we're hypothyroid, we have less stem cells, then that means there's going to be less hairs in anagen. There's going to be more empty follicles once our club hairs or adult hairs have shed. And then this is, consistent with the pattern of telogen effluvium, where more than 30% of scalp hairs will be in telogen phase. Another characteristic exam finding of hypothyroidism, which points towards the role of thyroid hormone in hair growth, is the fact that a lot of patients with severe hypothyroidism or long-standing hypothyroidism have loss of the lateral 1/3 of their eyebrow. And that likely is also related to a change in the anagen phase of those eyebrow hairs. This tends to be more evident in patients that already have some genetic predisposition towards hair loss. And it's also been noted to be more pronounced in patients with TSH values that are a little bit higher. And even in some studies, they cite a TSH greater than 2.5, which is still normal up until 4.5 or 5. But those patients that have a higher TSH may also be more predisposed to have some more hair loss than those that have TSH below or in the normal range. And there doesn't seem to be a correlation relating free T4 levels in from what I've seen. It's important to note, though, that in all literature that has been provided so far, that hair growth should be restorable upon restoration of euthyroid status. In hyperthyroidism, the converse is true, and our hyperthyroid patients often have thinning and shedding of hair and more brittle hair. And this is basically multifactorial, but basically, if we have reduced stimulation of our outer root sheath cells in hypothyroidism, in hyperthyroidism, the opposite is true. Those stem cells and those factors that provide nutrition to the hair follicle and the hair shaft as it's growing, they are being stimulated in excess. And there's over-rapid migration of stem cells, incomplete nutrition to the growing hair shaft, and therefore hair that is more easily to break, hair that is thinner, and there will be shedding eventually because more hairs will be in telogen and less hairs will be able to start anagen because there are less stem cells. They've been depleted because this process has been overexhausted. Similar to hypothyroidism, patients that have hair loss from hyperthyroidism can have reversal of this if they are returned to their euthyroid status. The most important thing to note here, though, is remembering the hair cycle in general. So our anagen phase, although it is the longest, takes 5 to 7 years sometimes, and so the hair growth will occur once the patient's euthyroid, but it still takes 3 to 5 months to shed all those telogen hairs, and 2 to 5 months after that. So usually tell patients to have a little bit of wait time and understanding that we start levothyroxine to treat your hypothyroidism. Maybe within 4 to 6 weeks we've seen some improvement biochemically in your TSH, but it may take several months after that for your hair to really noticeably grow back and seem more like it was before. A lot of times what happens is we initiate treatment and the patients actually attribute their continued hair shedding to the treatment rather than the fact that they were hypothyroid several months ago or a couple months ago. So that's something to explain to them and help them feel more comfortable with the fact that there will be improvement if they give time for the hair cycle to restart. Nextly, what relationship do thyroid antibodies have with hair loss? And so in looking at studies, there were a couple of studies that specifically discussed this. And one such was a study by Kasumagic and Halilovic in 2008. And they basically looked at 70 patients that had that localized autoimmune alopecia areata. And they compared them to 30 healthy volunteers in a retrospective. They wanted to see whether there was a significant difference in thyroid antibody status in the two groups. And what they found was that in the group of patients that had alopecia areata, 8 of them had some abnormalities in their TSH values themselves, and 18 patients from the 70 had positive antibodies for thyroid hormone, whether it was thyroglobulin antibody or thyroid peroxidase antibody. Whereas only 1 patient in the control group without alopecia areata had a positive thyroid antibody. They did comment that they did not believe that the severity of alopecia areata correlated with their antibody titers, but they did feel that patients that had a TSH slightly higher in the normal range or higher than normal, so undertreated hypothyroidism, did have more likelihood of being in the alopecia areata group, so maybe there was a causation there. Another study that was performed in Saudi Arabia looked at a greater number of patients in this prospective case study. And what they found is that a specific subtype of alopecia areata that is more severe, which is called alopecia totalis and alopecia universalis, seemed to be more correlated with thyroid antibodies. And so they looked at 50 patients that had these more severe phenotypes, 50 that had just mild localized alopecia areata, and 50 healthy control subjects. So I apologize if this is a little blurry, but basically these are baseline characteristics. And so, you know, those that were in the severe alopecia areata group in the first vertical column tended to have their alopecia for a period of up to 1 year. And patients in the mild group had their alopecia for a period less than, so a longer duration of alopecia in those that are considered severe phenotype. And pretty equal numbers of males and females, and pretty similar early age of onset, so more so before the age of 40 in most patients. What they saw when they looked at their antibody status is that there were more patients in the severe alopecia areata group that had thyroid antibody positivity. So 40% of these patients had positivity for either TPO antibody, thyroglobulin antibody, or both. And also what they noted, if you look at the bottom of this chart, is that their average TSH in the severe group was 3.17, but they had a number of patients that did have subclinical hyperthyroidism, and as opposed to the mild group that had TSH values that were more closer to the to under 2.5, and less patients in the subclinical hypothyroidism group. So this is where they drew the correlation that maybe TSH values have a relation as well, apart from just the thyroid antibodies themselves. They did note that serum free T4 levels were comparable in all groups, and there was no significant difference in free T4 level. So what we can draw from this study, in my opinion, is not that thyroid antibody positivity is going to necessarily mean you're going to have more hair loss than someone that doesn't have antibodies, but rather the relationship between these autoimmune conditions, and that in our patients that have a history of autoimmune thyroid disease, we may need to be on the lookout for this localized hair loss or alopecia areata because they may present concomitantly or as part of autoimmune polyglandular syndrome. Next, the relationship between cortisol and hair. So cortisol is known to negatively affect the formation and breakdown of the support materials of hair, so our proteoglycans and our hyaluronic acid derivatives. Similarly, cortisol releasing factor is corticotropin releasing factor is known to inhibit the elongation of hair shaft during the anagen phase. There's also association between hypercortisol states, hyperandrogenemia, so we may see pattern hair loss in these patients as well. And so this is really the relationship that we know exists between cortisol and hair on our body. The entity, which has been, commonly referred to in social media and in some, alternative health clinics, which is called adrenal fatigue, I'd like to point out is not really a recognized entity. So this entity is where a patient, has fatigue, weight gain, hair loss, mental fatigue as well, kind of confusion, and it's touted as actually adrenal insufficiency without actually biochemical evidence of adrenal insufficiency, low cortisol, low ACTH. And it's treated, off-label by some practitioners with, either ashwagandha or, some cortisol stimulating compounds or supplements. So I'd like to comment that this is not an entity that we recognize in endocrinology, and really there's no association between adrenal insufficiency, when it does exist, and scalp hair loss, apart from the fact that chronic illness in general can cause telogen effluvium and diffuse hair loss. So that's just, my 2 cents on that in particular. So what relationship does estrogen have to hair loss? So we do know that following menopause, women do have increased incidence of female pattern hair loss. And so that kind of suggests estrogen has a role in maintaining the normal ratio of anagen to telogen hairs. This is also supported by the fact that following delivery, many women experience excessive shedding of scalp hair, which they refer to as telogen gravidarum. And this is thought to be due to the precipitous or rapid drop in estrogen after delivery. And this condition does reverse after a period of months in most women. Other hormones and factors associated with hair loss are multiple. So I will summarize what I found, and I'm happy to answer any questions about it. So, firstly, prolactin. So, an excess of prolactin is known to be associated with pattern hair loss and hirsutism in women because of the hyperandrogen state and dysregulation of normal menses and normal patterns of hormones in premenopausal women. In men, however, hyperprolactinemia also can induce the catagen state, specifically in the occipital region, as opposed to the vertex and frontotemporal regions that we see in males with male pattern hair loss. And so, if more hairs are in the catagen state, that means it will appear that these patients have thinning of their scalp hair diffusely with less anagen. Vitamin D is kind of hit or miss as far as evidence. And so it has a lot of press in social media and a lot of attention in social media as being important for hair. But what do we actually know about its relationship to hair growth? What we do know is that there are genetic conditions that are associated with alopecia, namely type 2A vitamin D dependent rickets, where these affected children are born with normal hair at birth, so normal vellus hair, some scalp hair, but between the ages of 1 to 3 months, they develop alopecia because of this mutation in their vitamin D dependent regions. What they see histologically is that their infundibulum of their hair follicle will be normal, but the bottom 2/3 of the hair follicle, where there should be stem cells and regeneration and proteoglycans, are basically epithelialized and contain dermal cysts, so there's no hair growing. Another genetic condition is generalized atrichia, which is caused by a mutation in a gene called hairless, also associated with alopecia universalis, similar to vitamin D dependent rickets type 2A. As far as vitamin D deficiency, vitamin D supplementation in the general population, there really hasn't been much evidence supporting the role of vitamin D in hair growth. So specific studies that I came across were if there was any association between vitamin D levels and the onset of male pattern hair loss, which they did not find any significant association. A study which tried to see if topical vitamin D might improve psoriasis, which they found no improvement with vitamin D supplementation. What they did see in one study is that the anagen effluvium that's seen in patients that receive paclitaxel or cyclophosphamide chemotherapy can be prevented by use of topical vitamin D. But when other chemotherapeutic agents were used, this same topical vitamin D was ineffective. Vitamin B12 has been associated with hair growth and hair health, namely that low vitamin B12 levels, less than 200 picograms per mil, might be associated with increased scalp hair loss and increased risk of telogen effluvia. And surprisingly, melatonin plays a role as well in hair growth. And so what has been found is that there's a role of melatonin in acceleration of the anagen phase in hair growth. And additionally, that melatonin activates something called nuclear factor erythroid 2 related factor, which helps to protect the hair from oxidative stress. So cannot discount the importance of sleep in our hair health and overall health. Growth hormone also has been implicated in the health of hair, and we know that normally growth hormone is required to potentiate androgenetic effects during puberty, as the lack of growth hormone in growth hormone deficient males is associated with much higher testosterone levels to achieve the same level of hair growth. There's also some studies about relationship of treatment of acromegaly and hair loss. So one study in Tokyo that was done in 2012 involved passing surveys through the mail to patients that had undergone transsphenoidal resection of pituitary adenomas and history of acromegaly. Of the 484 who responded, more than half of them responded that they did have hair loss about 3 to 6 months after their surgery. Again, this was not quantified. This was a survey that they passed out, but 54% of patients responded affirmative, which is pretty significant. And it seemed to be a more common complaint in the female patients. But notably, they also sent out the same survey to 167 patients that had the same surgery, transsphenoidal resection of adenoma, for non-functioning adenomas, and only 3.6% of those patients reported hair loss. So definitely a discrepancy. Additionally, there have been case reports citing diffuse scalp hair loss or telogen effluvium after treatment for acromegaly with either the growth hormone receptor analog picpisamant or somatostatin analogs. So something for us to be aware of in those patients. Insulin resistance also is associated with hyperandrogenemia, so there's a possibility of patterned hair loss in those patients. And hyperinsulinemia also has been linked in studies to increase the activity of 5-alpha reductase, so that contributes to that patterned hair loss. So now we talk about supplements. So this is something that could be a whole nother subject and a whole nother presentation. So maybe that's something I'll do next time. But I wanted to draw your attention to this meta-analysis in particular, and I urge all of you, or definitely anyone that's interested in this topic, to go and read this and look at the individual supplements in detail. And so this was published in JAMA in January of this year. It was forwarded to us by Dr. Krishnasamy, who makes sure we're all up to date all the time. And so I really enjoyed this. And basically, they try to evaluate the safety and effectiveness of multiple supplements that are on the market now. And these are supplements that patients will always ask about or say that they're on. And I think it's also important to see this list. Be sure to ask patients if they are on it, especially if they have a history of hair loss, because some of these do have some side effects and things we should monitor for. And the key points from the study are outlined here. So they did a systematic review of 30 studies, and they tried to point out towards which ones had the highest quality of evidence. What they did find is that there could be a potential benefit to the use of certain supplements, namely one called Viviscal, one called Norcrine, one called Nutrafol, which cost $89 a bottle, one called Lambda-Pill, one called Pantagar. Surprisingly, a compound of capsaicin and isoflavone, and omega-3 and omega-6s with antacids, glyceric acid, zinc, tocotrienol, and pumpkin seed oil. So these are supplements I didn't even know were available for hair loss. But looking specifically at them, what you'll see when you review is that basically a lot of them lacked a control group. So they were cohort studies where they followed them long term. And a lot of them didn't show superiority over just observation. So, they pointed towards an observer bias and, intervention bias, so not really clear evidence. Specifically, I want to talk about some common supplements that my patients have tried. So male patients of mine that have androgenic alopecia have told me that they're using saw palmetto, which is already a treatment which is used for benign prostatic hyperplasia. And so the scientific name for this is esprapens, and it's thought to be similar to finasteride in that it's a 5-alpha reductase inhibitor. And so in this meta-analysis, they cited 2 randomized controlled trials. One which compared saw palmetto to placebo in male pattern hair loss, and there was some increase in hair growth at 5 months, but it was non-significant compared to placebo. And then another randomized control trial specifically compared saw palmetto to finasteride. And finasteride actually was superior, but saw palmetto was able to stabilize hair growth in patients after 2 years. So again, time is our friend when it comes to hair regrowth and something to tell patients. Of note though, saw palmetto has multiple side effects, namely that it can cause GI upset. It has been linked to pancreatitis. Similar to finasteride, it can also cause sexual dysfunction. And there is a possibility that we won't be able to provide early detection of prostate cancer because it interferes with those biomarkers. Zinc is another common supplement that patients use for hair growth. And the common thought is that zinc deficiency is associated with hair breakage, scalp hair loss, and increased risk of telogen effluvium. So studies have been mixed, and there's some possible role of hair regrowth using zinc supplements in patients with alopecia areata. But what about those with telogen effluvium? which is the most common cause of diffuse hair loss. So again, studies that have shown benefit have been very limited, and oftentimes there's patient-perceived hair loss grading, and so it's not quantified in any way, and there's no control group. None of the studies show any utility to testing zinc levels, so diagnosing that is not going to be important in determining the cause of their hair loss necessarily. And it's important to note that zinc supplements can be a potential for overdose. Taking more than 1 to 2 grams of zinc per day may lead to zinc toxicity, which can cause nausea, vomiting, acute renal failure, and maybe even copper deficiency if more than 100 milligrams daily is used. And so, to my recollection, the over-the-counter zinc supplements are 220 milligrams. So this is already above, and so chronic use may be something to caution against in our patients. And then biotin. The biotin is also known as B7, and it is in many hair, skin, and nails supplements. It is in collagen supplements that are believed to boost hair growth. It's also in certain mouthwashes as well, and in multivitamins. So it is present in a lot of things that are sold to our patients, but it's also found in small amounts in food that we eat. And so the daily recommended dose of biotin for most adults is 30 micrograms. But these supplements have concentrations sometimes as high as 5,000 to 10,000 micrograms. It's suggested that any dose more than 1 milligram may cause interference with multiple lab tests that we do, and doses greater than 5 milligrams will definitely interfere with our lab tests. Importantly, with thyroid hormone blood testing, the troponin levels, and so the FDA has actually cautioned against biotin use in patients that have a history of angina or in general have risk factors for CAD. And we usually caution patients to hold this for at least 72 hours before we do our thyroid hormone blood test. And there have been no studies to date, randomized controlled trials that have proved a benefit to using biotin on hair growth. All right. So how should we advise our patients that do have hair loss? I think the first thing is patience. So reminding them of the hair cycle and reminding them that what happened if they're having hair loss now actually is a reflection of what happened to them 2, 3, 4 months ago. And so if they had a major illness, if they had any major change in medications, or they used any of the medications for the first time that are on that list, those might be potential causes. If their thyroid disease was uncontrolled 3 months ago, that might be why they're losing hair now, rather than the treatment that they're currently on. Secondly, that we should do further investigations and take this seriously whenever there are indications. For example, if our patient does have thyroid disease, or if our patient doesn't have a history of thyroid disease, but has multiple symptoms suggestive of thyroid disease or a family history, it would not be unreasonable to test thyroid function. If they have a known history of autoimmune thyroid disease, then we should consider the link between autoimmune thyroid disease and alopecia areata. And if they have risk factors for vitamin deficiencies, we should consider telling them to take multivitamins, but caution them against exaggerated use of these supplements. Additionally, in patients, in our female patients that have hyperandrogenic symptoms, we should investigate further and correct that underlying cause. Also, we should talk to them about lifestyle changes. So, it may sound hokey to a lot of our patients, but sleep, drink water, have a plant-based diet, exercise, and manage your stress. So find a way, whether it's exercise, whether it's singing, whether it's, any hobbies, to find a way to cope with stress and manage stress. And that is all healthy for our hair. And using medications and treatments where indicated, and then also not being afraid to refer to dermatology if we think that further testing needs to be done, or if they need specific treatments such as intralesional steroids or other similar things. And so with that, I will go to my references, and I am happy to take any questions. Thank you so much for listening.
Thanks, Malika. That was very comprehensive, and a lot of things that most of us would not know. So quite a detailed covered the whole topic very well. So, of course, the most common things, most often we see are patients with thyroid disease wanting to get more or less thyroid hormone to try and see if they can manipulate their hair growth. Um, so,
Yeah, so I think, the best thing in that case is, again, to let them know that we're correcting it. And, one thing I have taken away from this is we're blessed to be very busy in our practice. And so oftentimes patients that have thyroid disease might be every 3-month or every 6-month appointment, but there's nothing wrong with doing labs in between and giving them that reassurance that we're correcting the problem sooner. Because especially if it's associated with hair loss, that's where the anxiety comes from. A lot of times it's not the constipation, it's not the heavy periods that is bothering them as much, it's actually the hair loss. And I think that's the slowest thing to respond to treatment. So reminding them, that it will get better, and maybe doing another set of labs in between visits to, show them that we're moving in the right direction might be a good idea.
there's a question from Lisal from the chat.
Oh yeah, let me take a look. Yes, so the question is regarding cyproterone acetate, which is not available to us. And I've never used it personally, and I've never recommended that someone go abroad. And based on the studies I did look at, it doesn't seem to be superior to other agents that are available here. When it comes to flutamide, I think I would choose my patient very carefully if I were to recommend it for pattern hair loss. I think many of our patients do have risk factors for having hepatic disease at baseline, specifically hepatic steatosis, because they usually have elevated BMIs or diabetes or on medications that are already known to have a potential for altering liver enzymes and liver functionality. So I think I would most likely avoid that agent. Interestingly, I have recommended and tried finasteride in some patients with pattern hair loss, particularly in my transgender men. And interestingly, it works in transgendered men, but it hasn't been as effective in my PCOS women. And in doing this presentation, what I learned is that actually our 5-alpha reductase isozyme is different in men and women. There's a type 1 in women and a type 2 in men. And so the finasteride and other commercially available 5-alpha reductase inhibitors actually work on the type that is specific for males. So women with pattern hair loss are less likely to benefit from these agents. I think addressing expectations with them is one thing, because any of these agents, the potential benefit is very little. And so they may see some benefit, but maybe we can address other factors that are leading to hair loss, and then consider more advancing treatments like transplantation, stem cell transplant, if it's providing a lot of unhappiness to them. Hope that addressed your question. And can aging-related hair loss be reversed? So as of right now, I don't know that there are any specific treatments. There is something called stem cell therapy, which, again, I did not read much about because it's not something that I personally would be able to do, but I would be able to refer patients for. So maybe that is something that can help with aging-related hair loss if it's a non-scarring type of alopecia. So definitely something interesting. I did come across a new treatment, which has a bunch of letters. Gosh, I'm forgetting it now. Let me look. There is a supplement that is new, which contains caffeine and nicotinic acid and some other things. So that treatment has been used in some patients with androgenetic hair loss, because what it does, it doesn't actually increase growth of hair, but it causes increased thickness of the hairs that are present. And so the overall appearance is fuller hair, even though there are still spots of hair loss and empty follicles. So that is something that might be considered in patients aging-related hair loss that appears thin. I hope that answered your question.
So the hair club for men is not something you recommend?
I recommend, in general, anything that will make my patients happy without doing them harm. So I never say no, even to supplements, but we have to know if there's a potential for harm. Personally, I think I can get behind hair pieces and wigs because you can basically be someone different every day. That sounds like fun.
Okay, thank you very
Any
much.
other questions?
Any other questions? Thank you very much. It was a wonderful talk. Thank you very much.
Okay, thanks everyone. Stay safe.